introduce our speakers today, Dr. Paul Crawford and Dr. Dave Moss, who's going to present on non-pharmacologic pain management technologies to improve quality of life in pain patients. So you all know Dr. Crawford, but briefly, he obtained his medical degree from Penn State University College of Medicine. He did family medicine residency at Eglin Air Force Base and faculty development at Chapel Hill, and the medical acupuncture training through Helms Medical Institute. And he's currently the executive director of the Military Primary Care Research Network, and he's professor at USS. And he is a retired U.S. Air Force colonel. And Dr. Dave Moss is a family physician and faculty at Nellis Air Force Base Family Medicine Residency. He's also assistant professor at USS. He attended USS and graduated in 2009 and completed family medicine residency at Nellis Air Force Base. And he also completed training in acupuncture through the Helms Medical Institute. And he started the Integrative Medicine Clinic with Dr. Crawford at Nellis, and he's currently the medical director for that clinic. So with that, I'll hand it over to Dr. Crawford and Dr. Moss. So if you have questions throughout the presentation, please put it in the chat, and we'll go over the questions at the end. And I'll also put a link to evaluation in the chat. Please complete the evaluation for the session at the end. Thank you.
Good morning, everybody, or I guess afternoon for you guys. Dave and I are out here in Las Vegas, so here's Dave.
Hey,
I don't know. We don't know if you can see us or not. Can you? Anyone?
Yes, we can see you in a small picture. Your
okay.
PowerPoint is large. You are small.
Okay. Thanks, Jeff. Winnie told me I could. Winnie told me I could pick my nose, so I won't do that now that I know that I'm on the picture. So yeah. So
we'll Bosnia to pick your nose, Paul.
Okay. Okay, there we go. So we have some disclosures we want to talk about. I think mine is that I.
Did they just freeze?
Yes, I'm not hearing them, so not sure what happened.
Hello?
Oh. Okay, you guys are back now. You were frozen for like a few seconds.
Okay. Yeah, so I've negotiated a couple CRADAs with different foundations. I don't receive any salary from them, but those foundations do provide equipment and training in a lot of different integrative medicine modalities to Air Force, VA, and USIS starting soon. And then both Dave and I have research grants through the Defense Health Agency to study integrative medicine technologies. So those are our disclosures. So as Winnie said, we're both family physicians. We're in
Is everyone hearing them, or is it just me?
Okay, now we're back. It looks like every time we switch slides, it does something funky.
Yeah, I'm not sure, like it kind of cut in and out. I'm not sure if it's a connection or what's going on.
I'm gonna go get a hotspot to tie into instead of the hospital wireless while Dave talks.
All right, sounds good. So these are the learning objectives for today. We want to talk a little bit about the concepts behind integrative medicine, sort of broadly define what integrative medicine is, at least to us. Review some of the pain pathways and ways that we treat pain. Paul's also going to do a bit of a discussion on the placebo effect, how that plays a part in not only integrative care, but in all clinical care. Then we'll talk about the different mechanisms and evidence for the modalities that we use in our clinic here at Nellis. And then we'll finish by talking about our general approach to care and also cover some of the outcomes that we have been tracking in our clinic from the various modalities. So in terms of defining integrative medicine, it's a very broad term. It's an umbrella term. It probably means a lot of different things to a lot of different people. But generally, the consensus is that it involves a non-traditional approach to treating and healing. So if you say, what is a traditional approach? Western medicine is very much a disease process, biomechanical focused, pharmacologic focused approach to medicine. There's a lot of time constraints due to reimbursement. There's also a large focus on procedures. Integrative medicine is more about non-allopathic approaches, taking into account the whole person, so a holistic view of the person, not viewing the person as their disease process. And in reality, integrative medicine is how we should practice medicine, looking at the whole person, looking at lifestyle improvements, and healing by whatever method works for the patient, whether that's medication, procedures, surgery, or other modalities.
Yeah, so we're going to focus mostly on pain for the rest of the talk. As everybody on the call knows, pain is a really complex process, right? And you know, it's influenced by about a dozen or more factors along the way. It can, you know, from the point of the instigating factor, there's we can influence pain for the good or for the bad through all kinds of things like inflammation and treating peripheral nerves, dorsal root ganglions, using drugs to target different things in the brain, psycho-emotional therapies to try to help the patient process better. And you know, many of the things we're going to talk about today focus on interrupting pain signals or changing the way the body perceives pain signals throughout this pathway.
And one of the important concepts in pain treatment and in integrative medicine in particular is this idea that pain is linked to emotions and vice versa. And just as an example, we did a quick search, and if you search for chronic pain and depression, there's over 12,000 citations. If you search chronic pain and anxiety, lots of citations, and then chronic pain and PTSD. This is something that's become very apparent to us since we started the clinic in 2019. Something, frankly, that I don't think we were quite anticipating, but became very obvious when we started really looking at the whole person, how much stress, emotions, psycho-emotional issues affect pain perception in the patients that we treat.
Yeah, so we all treat pain a little different, right? Based on our training, the set of beliefs we bring to the patient encounter, the resources we have available to us. And that can range. I mean, I tried to list out all the different things I could think of, you know, things that we do to treat pain, we as physicians. And I mean, drugs is probably number one in the way we're trained, right? You know, and for good or for ill, that is what it is. We're going to talk a lot about bioenergetics today, which is a sort of a catch-all term to talk about, you know, placing energy into the body in some way, shape, or form to help the body heal. Anti-inflammatory stuff, whether that's exercise or diet or different mind-body techniques, can really impact how the patient perceives pain. Some of us know manual techniques, whether that's osteopathic stuff or whether that's myofascial. Of course, psychotherapy in different ways, shape, or form, CBT, eye movement desensitization and reprocessing, or EMDR. Of course, we refer a lot of people to rehab things through PT, OT, etc. And then nutrition is, a big component of our health and of our experience when dealing with pain. So Dave's gonna talk a little bit about the modalities that we use here in our clinic.
So this is basically the list of things that we do in our clinic. We do a lot of acupuncture and acupuncture-based techniques that we'll talk about. We do a specific type of manual therapy that we'll discuss. We have a variety of microcurrent devices, including frequency-specific microcurrent, Avazi, and alpha stim. Alpha stim might be familiar to a lot of folks. That's been around for a while. We also treat patients with low-level laser therapy, something called extracorporeal shockwave therapy, which we'll get into. Scrambler therapy, also known as Calmare, and that's the trade name. And then a newer device called the All-Core 360.
But first, I'm going to talk about the elephant in the room, I think, because a lot of people associate integrative medicine, acupuncture, etc., with placebo effect. And I think that anybody who says that there is no placebo effect in in the way that we do medicine is misinformed. However, I also think, and we'll talk about it a little bit later, that anybody who attributes everything that we do to placebo is also misinformed. Cochrane Review found that in patients with pain, no matter what you do for them, 28% are going to get better because of the placebo effect. This little graphic here tells a lot about the different things that affect how a different patient might receive placebo. Their expectations, there's Pavlovian conditioning. They might have been taught by their mom that getting a pill from a doctor is going to make them better, and so they're going to get better. There's even genetic traits that impact who responds to a placebo. A nice little picture here for those who are more visual learners, talks about, the things that I say to the patient, the way that I talk to them, the way that I dress, the way the hospital smells, all have effects on how the patient gets better. The fact that they're touched by needles or other devices, the way medication looks or smells, those are all the external things. And then there's personal beliefs and expectations. We all know, probably can think of patients that we've treated that just really trust what we're going to do, and they get better results, versus the people who are very skeptical and maybe don't get better results. I think, this last little graphic I have here, if you start at 1, if I feel sick, and I've got lots of different things that are happening to me. I've got my psycho-emotional milieu that I come into the encounter with, and I've also got the actual pain I'm receiving. Then I go to seeking relief, and I've got some motivation to get better. There's reward mechanisms that happen. I meet the doctor or the therapist, and the way that I treat the patient impacts things. The way that you trust me or hope that you're going to get better impacts things. And then the actual therapy itself, the rituals around receiving therapy, expectations and learning help me get better or not get better. But ultimately, I mean, I think the point is that everything we do, whether it's integrative medicine or surgery or pushing pills, has placebo effect associated with it. Unfortunately, there are quacks and shamans out there who really try to play up the positive effects to encourage, honestly, to encourage therapies that don't work. And that's part of the reason, you know, that we teach students and teach each other to assess the research literature for evidence, because we should be able to assess what works and what doesn't. And as responsible clinicians, I think we need to recognize that, you know, on the other side of it, placebo effect exists, and we shouldn't poo-poo it, and we shouldn't play it up too much while we search for actual treatments that work. You know, to me, that, you know, the opposite of the shaman is the severe skeptic who doesn't believe that anything new ever works and doesn't have an open mind. Basically, you know, they're not willing to try something while the evidence is being gathered, and maybe they practice evidence-limited medicine instead of evidence-based medicine. So there's a balance we need to strike. So let's talk about acupuncture. I'm going to spend a little time here because it's the treatment that is associated with integrative medicine most commonly in the military, and actually there's the most evidence for it of any integrative medicine therapy. As you probably know, you know, acupuncture is the insertion of disposable needles into specific points in the body. It can include ear, scalp, you know, just directly around the area you have pain, areas that are distant from the sites of pain. And we can use manual manipulation, electricity, or heat, or cold. Of course, there's a lot of different types of acupuncture. There's the sort of the traditional Chinese one that focuses on meridians and biopsychotypes, in other words, how the patient deals with different environmental influences. And there's lots of microsystems that, you know, are really popular. I think the auricular one is the most common to us in the military because of the propagation and promulgation of battlefield acupuncture, which is just one protocol out of potentially thousands of auricular protocols that can be used. You know, this graphic shows that there are associated points all over the ear for different points on the body. Of course, there's scalp acupuncture, which nobody knows how that works. But here's a X-ray of a patient with some needles in their scalp. Basically, it's you put the needles over top of the areas of the brain that are associated with pain or limitation in movement from that condition. There's hand acupuncture, foot acupuncture, dry needling. I'm going to call that a type of acupuncture. The physical therapist would argue with me and say it's not acupuncture because they're not allowed to do acupuncture. So it's a legal thing, but quite honestly, we're using acupuncture needles and we're doing some localized treatments with it. Whether you call it acupuncture or not, it doesn't matter. You know, there's lots of theories why acupuncture works. Nobody knows 100%. You know, there's a lot of different anatomical theories that stimulation or dampening of the nerves that are out that we put the needles nearby causes decreased inflammation and pain. The Chinese theory to talk about qi and talks about how the meridians flow all over the body and that acupuncture needles work to unblock areas of stagnant qi and improve balance of different things throughout the body. Regardless of how it works, though, there is really good evidence, the things in the upper left corner of the slide, that it works for, and there's pretty good evidence for the things on the lower left and the whole right side of the slide that it works for. I think for pain treatments, treating knee osteoarthritis, migraines, headaches, post-operative pain, back pain, neck pain, are all things that we very, very commonly treat with acupuncture. Dave's going to talk a little bit about some of the manual or myofascial therapies that we use.
So I want to talk briefly about what the myofascia is. I think for us MDs, it's a little bit different than what we learned in medical school. When I was in medical school, if somebody told me about a fascia, I would think of what we consider an aponeurosis. So, you know, in the low back, you've got these very thick layers of connective tissue, and that's what I thought of as fascia. Being introduced to the world of integrative medicine, I've learned that the fascia is actually this sort of spider web-like network of connective tissue that's very flexible and movable, that is in the subdermal tissue, penetrates the muscles, and provides a lot of structure to the organism. So there are several things that we can do to affect the myofascia, which is a very, very common source of pain and dysfunction in the patients that we see. We have a specific manual therapy that we use called active myofascial release. This is a technique where we focus on grouping the muscles into two broad categories. One is stabilizer muscles. These are muscles that when they contract don't really move anything. They simply provide stabilization for the body. And there's several sort of key muscles in the body that do that. So our goal with that is to help patients utilize the stabilizer muscles appropriately. And then there are mover muscles. These are muscles that when they contract, they actually provide movement for the body. These commonly end up in spasm or have trigger points. And so our goal with mover muscles is typically to release those muscles, to release tension and pain. The reason we call it active myofascial release is because the patient is performing movements while we do these manual therapies, which is a little bit unique. Most of the manual myofascial therapies out there are passive, meaning the patient might be lying down and not moving, or the person doing the therapy might move parts of the body as they perform manual therapies. The reason that this active component is important to us is because when the patient is providing the movement, then we're accessing the neuromyofascial connection. So we're accessing that connection between the brain and that myofascial part of the body, and having the patient do the movement really allows us to access that. So that's the manual therapy that we do. Some other therapies that we do for the myofascia that you may be familiar with. One is gua sha and cupping. Gua sha is a form of scraping. So you can see in the picture that this patient's skin is red. That white stuff is lotion, and in the provider's hand is it's actually a Chinese porcelain soup spoon. The physical therapy world, they often call it the Graston technique, and they have lots of elegant metal scraping devices. In our training, we would just use the soup spoon and call it good. But this is a way to, from a Chinese perspective,
Are people healing?
at least it makes a sound. Are we back on?
Yes, you're back on now.
Okay. It's nice. It makes a sound when we're off, so we know when to stop. Okay.
Okay.
So when I think of gua sha and cupping is when we apply suction with cups. It has a similar effect of gua sha. I think of it as like a poor man's PRP. We're busting some of those capillaries, and the blood is coming to the surface and providing a similar effect as PRP to that myofascia. Another modality that we use and have been using for a little over a year is extracorporeal shockwave therapy. This is something that's been around actually since the 90s. You can see what this does is delivers shock waves to the subdermal and deep tissues. There's a variety of delivery devices. The one that we use in our clinic is a radial device, meaning that inside of this handpiece that you can see the picture above, there's actually a magnetic bullet. The cord that you see coming down from that handpiece is a pneumatic tube. So it blows air, pushes the bullet to the tip, and then that transmits a shock wave through the tip and into the tissue. There are other delivery devices, electromagnetic, piezoelectric, and electrohydraulic are some other examples. But like I said, the one that we use is a radial device. Actually comes from the same technology as lithotripsy. Early on, when they were doing lithotripsy, patients would come back and tell the doctor that their pre-existing back pain that they had before the kidney stone was actually better after they did lithotripsy, and that started this movement towards trying extracorporeal shockwave therapy on other conditions. The mechanism, they believe, is that it creates micro damage to these deep structures, which then causes this cellular cascade of regeneration. So it releases growth factors and other cytokines that help to decrease inflammation. The overall effect of that they've seen is osteogenesis, neovascularization, and also softening and destruction of scar tissue.
And this is not the same.
We lost you again.
Can you hear us now?
Yes.
Okay.
Yeah.
So Paul was making a point that this is definitely not the same as the massage guns that have become very popular over the last several years. This is sending a variety of shockwave forms. There's different tips that you can put on these devices that will have more focused or more broad shockwaves that go into the deep tissue. So currently the evidence for, and we're sort of lumping these together, for manual therapies and extracorporeal shockwave therapy is that there's probably benefit for neck pain, trapezius pain, TMD. Also very good evidence in shockwave therapy for plantar fasciitis, calcific tendinosis, in particular epicondylitis, and for myofascial trigger points.
So some of you on the call have learned frequency-specific microcurrent, and what this does is it provides microamperes of electrical energy at varying frequencies. Everybody knows that different tissue or different things in the world vibrate at different frequencies. Wood versus steel versus plastic versus skin, muscle, bone, all vibrate at different frequencies. And when we have dysfunction in our tissues, it doesn't vibrate at the right frequency. And therefore, ATP production within the mitochondria is reduced. This is basically trying to reboot our tissue to vibrate at the correct frequency. And what it does is, what's known is that it, when the correct frequency is applied, that the proteins in the mitochondria that facilitate transport of phosphate and hydrogen back and forth across the cell wall work better than when they're vibrating at the wrong frequency. So these treatments can last anywhere from 30 minutes to an hour, and we have treatments that can treat just about anything, supposedly. We have protocols that we use. Here's just a partial list, where there's literally thousands of these. I think the problem with frequency-specific microcurrent is that the evidence base is very poor. There's broad-based evidence using case reports for, hundreds and maybe thousands of patients, and they all show benefit, but there are really no significant number of controlled studies. There's one study that looked at delayed onset muscle soreness after people ran a marathon, and that showed effectiveness, but that's the only controlled study there is. Everything else is small retrospective or case reports, which, as we know, can be biased. So, that's part of my mission, is to try to figure out if it works for real or not. There's a lot of other things we do. Dave mentioned our laser therapy, which we have 3 different lasers that vary in strength from 32 watt to 74 watt. They're all class 4 lasers. These don't cut you. They're not Star Wars lasers. These are providing different level or different wavelengths of infrared light that penetrate variable distances into the body. Like this particular one that's shown will penetrate up to about 20 centimeters into the body. That's this is a variable strength laser up to 74 watts. And there's lots of evidence showing that laser works for a lot of different conditions. I'm interested in figuring out the right dose, because pretty much everybody just says turn it on and treat for 15 minutes. No one's ever tested that. It's just, maybe 3 minutes is fine. Maybe really it'd be better if you treat for 30 minutes. Another technology that we have is the Questionnaire or scrambler therapy. This is proprietary technology, reverse engineered from the Soviets, that you put electrodes on people who have neuropathy and send a non-pain signal through the nerves back to the spine, back to the CNS. And Dave's going to go over some of our data from this, but in patients who have just neuropathy, this is a very effective treatment. And then we have other versions of microcurrent. This Avasia is something that works really well for softening scar tissue and doing a lot of, honestly, it does a lot of the manual releases Dave was talking about with electricity, and helps save our hands, actually, in a lot of times, because it can take a lot out of you to do manual releases all the time. And then the last technology I'm going to talk about is the All-Core 360. So as you can tell, this is a big machine. It's 8 by 8 by 8 feet. So it's a big footprint. And as the slide says, basically where it takes the patient through a 360-degree plank and activates all 50 core muscles. Basically, the patient, you can see they're sitting on a chair, but they're not allowed to touch the back of the chair. They have to keep their back off the chair. They have to keep their sides off of the. They can't rest their elbows on the armrest, and they basically have to hold themselves in space. And then that machine rotates them 360 degrees, so they'll be facing left, then down, then right, then up, so that every muscle is activated. And it's very, we only had that for a couple months, and we're finding it to be effective for mechanical low back pain in particular. So Dave's going to go over our clinic, how we function, and outcomes that we have.
I'd like to start by talking about just the mission and vision of the integrative medicine clinic, which we mentioned we opened back in 2019. Basically, we are trying to determine what techniques work to restore whole health, specifically within a military population. We also are interested in developing and acquiring and transitioning these modalities to the military medical practice. And a huge part of that is performing clinical and implementation trials. Another key component of what we do is to educate medical personnel through and also to sort of use our clinic as a petri dish, as it were, to figure out, what we think works clinically, and then we can put that to use in clinical and implementation trials. We have a multidisciplinary team within the Family Medicine Residency Clinic. These are all folks who work with us. We have 3 physicians primarily that work with us. One's an osteopath. We have a chiropractor who's been working with us for about the last 6 to 8 months. We have 2 registered nurses, licensed massage therapists, and then we often utilize our primary care behavioral health team with some of our patients. So our overall clinical approach in clinic is, as we mentioned, a whole person approach. So what this means, practically speaking, is we're doing things like getting trauma histories. We're getting into other psychoemotional histories like depression, anxiety, PTSD. We're asking about current stressors, prior stressors, asking the patients if they recognize how these things may relate to their pain. We also get into environment at home, at work, how this relates to their pain. And one of the things that we do is really try to get granular details of prior injuries. And this is for a functional-based myofascial treatment plan, which has a lot to do with our manual techniques, where we will often, I mentioned the active component, will often, in a sense, recreate injuries using these manual techniques, which can be very effective. We use non-traditional therapies like we've talked about, and the goal is to treat the conditions and give patients tools to self-manage. So our ultimate goal with each patient, I tell this to them on the first visit, is that they don't have to come back and see us, that they can manage their condition on their own and just come back on an as-needed basis. We generally do not prescribe medication or alter medication regimens, with a very few exceptions. I think it's also important to state that we don't view integrative medicine as a separate entity or in conflict with traditional allopathic medicine. Paul and I both practice traditional allopathic medicine within the hospital. True integration to us means that we break down the silos in medicine. So we work in concert with PCMs, with mental health. We get patients from our neurologists. We have patients referred to us from surgery. We refer patients to surgery. We work with pain management, rheumatology. So it's really about, when we say integration, it really is about integration, using everything that's at our disposal to treat the patients. When we have patients come into the clinic, we collect several items or several data points at each visit. We collect pre and post pain scores using the Defense and Veterans Pain Rating Scale, which is an 11-point visual analog scale. Lower scores obviously are better. We also use something called the Dallas Pain Questionnaire. This is a 16-item quality of life questionnaire. Covers multiple quality of life domains, and again, lower scores are better, and we'll get into that data here in just a minute. Also, when we move patients to PRN or discharge them from the clinic, we ask them one simple question, which is, as a direct result of being seen in our clinic, how would you rate your overall quality of life? So as of the time that we put this together, we'd seen 668 patients, over 3,000 clinical encounters, and the average number of visits per patient is 5. So typically, somewhere around visit 5, we are moving them to a PRN status. So from here, I'm going to go through a bunch of charts that just kind of show the data that we've collected so far. So this is that question that we ask on discharge as a direct result of being seen in this clinic. How would you rate your overall quality of life? You can see that about 80% of patients say that their quality of life is either somewhat or a lot better. A minority say that it's the same, and then a very few say that their quality of life is worse. And for us, quality of life, function is more important than pain scores. Quality of life is much more important than pain scores. So for the Dallas Pain Questionnaire, this is looking at the total score. The total score is hard to interpret what it means clinically. It's kind of just a number, but it's good to see, and I'll explain the subcategories on the next slide. But you can see that our average total score is 161 out of a possible highest score of 400. And you can see that by visit 10, our total scores are much lower. Say that again.
What's clinically significant?
Oh, clinical significance is hard to define. There is an article out there that tries to define it, but it uses orthopedic surgery patients. And so when we looked at those numbers, they didn't quite match up with our patients, because these were patients that had, like a bad hip. So they had really high scores, and then they fixed the hip. So then their scores went really low. So it is tough to define what's clinically significant here. The Dallas Pain Questionnaire does have subcategories. And so you can see on the bottom, there are questions that talk about activities of daily living, work and leisure, social interests, and anxiety and depression. The way that this is interpreted is if the score is, say, 50, what that means is that their quality of life in that area is only 50% as good as it could be. So 0 would be it's the best. 50 means that it's 50% negatively affected. And so you can see a downward trend with each of these subcategories over time in the clinic. Looking at the DVPRS scores, this is an interesting trend that showed up very early and has remained pretty consistent. So our average score is about 4 when patients come in for the first visit, and we usually get them down to a 2 or a 1. So 50 to 75% reduction with each visit. What's interesting is that that pain score doesn't change really over time when they come in for each visit. At each visit, we're able to drop that pain score. Our interpretation of this trend is that we see the quality of life scores improving, even though the pain score doesn't. So if a patient who is a 4 normally comes in and we reduce their pain, they'll come back the second visit and tell us the things that they were able to do that they haven't done in a while. And because 4 is their baseline, that's what they're comfortable with. So they'll usually work themselves back up to a 4. Then we lower their pain, and then they keep, every time that they come back, they've done more and more and more. So 4 is what they're comfortable with, and they, like us, I think, realize that function is more important than pain scores. So they're willing to live at a 4 as long as they can do the things that they want to do.
Yeah, and if you look at the DVPRS, it specifically says a 4 is I'm able to do the things I need to do. A 5 is pain interferes so much I can't do anything in my life. So, I mean, I think psychologically most of us are going to do what we need to do if the pain isn't too bad.
So we've also broken down a lot of this data by modality. The first one that we'll show is the CalMare. This was that scrambler therapy that's used for neuropathic pain. So these patients typically are only getting CalMare therapy. They're not getting other modalities because their pain pattern is very specific. It's neuropathic. So again, you can see that their Dallas Pain Questionnaire scores in each category decrease over time. And this one's a little bit different in the pain scores, the DVPRS scores. We actually do see a decrease from start to finish, and quite a significant decrease with each visit as well with the CalMare. For the rest of the modalities, we only looked at the DVPRS. The reason is because most of the folks who are getting these other modalities are getting multiple modalities. But what we do with things like shockwave therapy and laser is we'll do a series of treatments where we'll, maybe for 3 weeks or 4 weeks, they'll only get that particular modality. And so we just have collected the DVPRS data for those patients. But again, what you can see with the shockwave therapy is a pretty good reduction in pain with each visit, and then a trend towards a decrease overall in pain. What you'll also notice with these modalities is that the numbers are pretty low so far with these, we call them series, so a series of extracorporeal shockwave therapy. So just 12 patients for this one. For laser, a few more, we have 25 patients, but a similar pattern where you can see an overall decrease from start to finish, and then also a decrease with each visit. And the all-core is one that we have really only been using since February. Since about February. So again, these are patients that will have come in 2 to 3 times a week for anywhere from 3 to 6 weeks. They do 10-minute sessions on this. And interestingly, we do see a reduction in pain, or a trend towards reduction in pain, and even reduction in pain at a particular visit, which I think was a little bit surprising to us, that they would have pain reduction at a particular visit just from doing, you know, these 360-degree planks. But it's an interesting technology.
Yeah, and so things that we're doing here, you know, almost all of the technologies we talked about are either on loan to us through some of those cooperative research and development agreements, or we purchased them through the research grants that that we've had. And the things that we're studying currently are, you know, I'm not going to read everything there, but some very simple acupuncture protocols for people who have acute low back pain, trying to get dosing for the right amount of laser to treat pilots and flight crew for neck pain, very common condition. Scar infiltration for the treatment of post-surgical pain after a C-section. Microcurrent for fibromyalgia, using auricular acupuncture for sleep disturbances, and one that's not on here is that we're just finishing up and don't have the data for, is a treatment of chronic undifferentiated pain with frequency-specific microcurrent, randomized controlled trial. So lots of different research going on. Some of this is here at Nellis. Some of it is combined with Scott Air Force Base and Eglin Air Force Base. And we're probably going to be, well, we are going to be expanding some of this to the USIS or the capital region in the near future. So yeah, so I think the thing that we want to make sure that we get across is that integrative medicine, broad term, that basically involves whole person approach to care. What maybe we as family physicians should be doing anyway, right? And then that there's lots of different ways that we can do that, whether that's myofascial therapies or acupuncture, bioenergetic devices, and then that you know, we're starting to think that there could be comparable clinics made at different DOD and maybe the VA to improve whole person health and patient-oriented outcomes, because ultimately, you know, we want to get people back to duty, decrease healthcare utilizations, medication use, and overall cost. So with that, we'll stop sharing and answer any questions. Not sure if there's anything in the chat or not. I don't know how to see. Oh, there we go.
I don't see any yet.